Dr. Said's fits in perfectly. Oh, perfect. Fits in perfectly because HIV में वही मसले जो कि Hep C के अंदर हैं. It's like it was almost initial talk was exactly the same. I know time बहुत कम है, so I will actually finish early, hopefully. In fact, my talk is in bits and pieces, so I'll probably end before it's supposed to talk, that we can all finish in time. So I have no disclosures, and game plan ये है कि the introduction is important. I guess we're going to talk about the current status of HIV in Pakistan and what is HIV in 2025. You probably मेरी पुरानी slide इधर आ गई, that's okay. But then the more important thing is that for internal medicine, what do you need to know about HIV in terms of diagnosis, side effects, inpatient care and chronic care. To save time, I'll probably skip the diagnosis and inpatient opportunity infection, but talk about the side effects because that is something that as an internist you need to know. And chronic care, just there has been some important things that have changed over the time. But more importantly, what about the current HIV status? So 2023, the reason this is 2023 is because new data are becoming. There were about 3 lakh people with HIV. Now, revisions are expected this year because we've had a big survey of HIV, which happens every few years. We've just had the 7th round. Uske results are now not yet published. I have some access to the results, I'll show some. And uske basis pe we revise how many people we estimate with HIV. But the number is almost certainly going to be much higher than this. Our distribution is that we have about equal amount in key populations and non-key populations. HIV, we talk about key populations. Key populations are people who are at very high risk of HIV. These are men who have sex with men, female sex workers, male sex workers, transgenders, and IV drug users. These are our key populations. You'll see, and just like Dr. Said had mentioned, this is shifting now in Pakistan. And there were about 36,000 new cases, and this has also increased rapidly over the last 2 or 3 years. Disease burden is wherever the population is. Punjab is the most populous province, so we have the most over there. Sindh is the next, so we have the second most over there. These are the trends, and if you don't do anything, just like in hepatitis C, you can see that our national trends will increase rapidly in all of the provinces, and equally actually in all the provinces. But more importantly, what I want to show is as you can see, most of our HIV are still in males, some in transgenders, but our HIV in children have increased rapidly, and this is likely because I'll come back to this in the 2019 mein, as you may know, Rathodera mein jo outbreak hua tha, the huge outbreak, which is the world's largest outbreak ever in children in the world. And who are the cases? And this is important because यहाँ पे जो numbers हैं in red are the official numbers. This is of the last round that we had of HIV survey, and you can say about 30% of IV drug users are HIV positive. इसका क्या मतलब है? This means कि if you're driving down Karachi and on Kala Pul, you'll see 3 IV drug users, at least one of them is HIV positive. 1 in 3 are positive. Men who have sex, transgenderism, it's about 7.2%. MSM में, men who have sex with men में about 5.6, and female sex workers में 2.2. Now the last figures, the 27%, 10%, 7%, 3.8%, these are the figures from the latest round of HIV survey. The reason why I haven't put in bold is because the official numbers are not out yet. This is what was reported. The report is expected sometimes later this year. But you can see that in all the populations, except for the IV drug users, the numbers have increased. And they've decreased a little bit in IV drug users for many reasons, which I'm not going to go into right now. But it's a rapidly increasing rate. The other thing you need to know is that even though IV drug users we have about 30% HIV, our number of IV drug users are not so much. We have a lot more men who have sex with men. So if you look at the absolute numbers, the total number of people who have HIV who are gay is a lot much higher compared to those who are IV drug users. And this is the population which is really not taken care of very frequently, not in a lot of our prevention plans. And then the last slide is how do people get HIV? And this is based on a national survey that we did last year on HIV and people who are who are enrolled in care. And what you can see is, as you can expect, about 40% are from sexual route, but only 40%. You know, in our mind, we often think HIV is through promiscuous sex, but only 40% is through sexual route. About 1/3 is from needles. That includes IV drug users, but it also includes people who got care at hospitals. 11% is transfusion. This is horrible because all blood should be screened, but 1 in 10 people with HIV are getting HIV from poorly screened blood transfusions. In 10% people we didn't know, often these are also nosocomial, only 5% are vertical, and then 1% are healthcare. These are people who got needle stick injuries, doctors who got needle stick injuries mostly. But you can see a lot. Only 40% are sexual, all the rest are non-sexual transmissions of HIV. And this is what we're seeing also in HIV, just like we saw in Hep C, they follow each other, is that now we're seeing spillage into the general population because of poor infection prevention control. We had numerous examples. Jaipur Jatan was the very first one. Ratodero I mentioned in 2019. And then several dialysis outbreaks that have happened. One was just last year in Multan. And we actually went back to those cases. This is yet unpublished data. And we looked at those 36 people and did the genotyping, similar to what Dr. Saeed had shown, and they all came from the same place. These are all nosocomially transmitted cases. And in our clinics now, I'm seeing more and more people who had no risk factors who are coming with HIV. And as an internist, you have to keep this in mind, that this, don't think of the young male as somebody with HIV. I have 70-year-olds, 80-year-olds. I have people who from all socioeconomic background who probably got it from the same route. So we have to sort of think away from the stereotype. I'm going to, like I said, skip diagnosis and talk about ART side effects, because that is one thing that you do need to know as an internist, because there's one side effect which you do need to know and think about. This is our antiretrovirals. I'm not going to go over the details. But when you talk about side effects, there are things called class side effects. Some side effects which all of the drugs have. And the one that you need to really know about, because you're going to see more and more HIV now in your clinics in the ER, are the mitochondrial toxicities. And these really present as lactic acidosis, hepatic steatosis, neuropathy. And the protease inhibitors have metabolic disorders, and I'm going to come back to this again when we talk about the metabolic issues with HIV. But I did want to bring up hepatic steatosis. This is something which is often missed because people only present with abdominal pain, right? And it's a very difficult, or you have to really have a high index of suspicion to know this. People will have high lactate levels with this, and the bicarbs will lag behind. So you may not see a lot of acidosis on your electrolytes. And obviously you'll do ABGs and VBGs. Aksar, you have to do abdominal imaging to make sure that there is no appendicitis ongoing, and then serum lactate levels. And treatment really is just hydration, as long as you pick it up. If you don't, the patient will probably die. So any HIV patient on antiretroviral therapy coming in acidosis or with abdominal pain, make sure to think of this syndrome in that case. Management, I'm not going to really go on in detail. Essentially that we just hydrate these patients. It takes a long time, and we put them on a non-NRTI regimen, which I will not go into. All right. This is just a one slide if you want to take a picture at the end, just so you have a one snapshot of all of the common side effects of all of the antiretrovirals we use over here. Hyperlipidemia is what we see with the protease inhibitors. Dolutegravir is the most common one. Almost 90% of people are on this, can cause neuropsych issues. Tenofovir is the second most common, which causes renal toxicity. Zyrovirin we don't use a lot anymore, but that causes anemia. I'd already talked about mitochondrial toxicity. Lopinavir causes GI side effect. This is an important one to know. Atazanavir causes hyperbilirubinemia, but this is cosmetic. The bilirubin level will be very, very high, but we do not stop the drug based on this. And then finally, hypersensitivity with abacavir. So this is sort of just a one snapshot of all of the common side effects that you'll see in your patients coming with HIV. I did realize I forgot one a little bit, but I will go into the chronic care really fast, because that is an important sort of a thing as an internist you need to know, because HIV has changed. Before I started, we said that HIV is not curable, but remember, HIV is very treatable. People with HIV have completely normal life expectancies. People with HIV cannot transmit the disease anymore once they're on therapy. So which means the way that we think of the disease has changed completely, and that's why it's become a lot in the internal medicine domain hota hai. The population is now aging. Like I said, I have people coming with very, very advanced ages as well. And if you just look at my center that we have over here, almost a third of the people are above the age of 40. I have very few people, well, about a half of them are the 21 to 40 year of age. And as you age, all of the problems that you associate with aging happens with these patients. Because now there's a shift in mortality. More people with HIV are dying of non-HIV related illnesses. Only about a third of people die with things related with HIV. And you can see over here that as you diagnose HIV and as time goes by, the non-AIDS related deaths keep going up, right? So people with HIV die of cancer, of heart attacks, of strokes, of road traffic accidents. And malignancy rates are also higher in people with HIV. And this is obviously, malignancy is a little bit because of the virus itself, but also the opportunistic infections and also people getting older. I'm going to skip this because I do want to talk about cardiovascular disease and HIV and finish early. Because remember, people with HIV, people living with HIV have a higher risk of cardiovascular issues, more than somebody at the same age who does not have HIV. The problem is that our traditional risk factors, we do need to assess them, but आपकी जो risk scoring है, all of the risk scoring don't have HIV in them, and HIV tends to be underestimated as a risk factor. So if you have somebody with HIV and you do a risk scoring, you should always sort of err कि इसका risk इससे भी ज़्यादा होगा जितना मुझे risk बता रहा है ये. And for example, the Framingham score in the mortality is for the same Framingham score, the HIV, somebody with HIV, the mortality is higher compared to somebody who does not have HIV. So we need to put in strategies to eliminate this, and that's why, and this is one of the problems that HIV care in Pakistan is only provided at HIV care centers, which are not manned by internists for the most part, and it's very narrowly focused on just treating the HIV, and it's not comprehensive. And the problem is that people living with HIV don't often go to healthcare facilities because of stigma. There's a lot of stigma in healthcare settings, so they don't come to see a regular doctor. Agar aayenge bhi to they will not tell you they have HIV because of the fear and shame associated with it. And even in the US, this non-communicable disease care in HIV is lacking. So like I said, traditional risk factors are also more impactful. In other words, if there's a smoker, for example, smoking will cause more of a harm in somebody with HIV compared to not. And here's an example of how the modifiable, we look at the modifiable risk factors, and if you make these modifications, you can make a big difference in the outcome. And then finally, I do want to bring up this one study, which was the Reprieve trial, made huge waves up to, I guess, 2023 ho gaya. And this was published in NEGM. And what they did was they took about 8,000 people with living with HIV with low to moderate risk, not with high risk, but low to moderate risk of cardiovascular disease. And they gave them pitavastatin at 4 milligrams, and they looked at their cardiovascular events. And it was a placebo-controlled trial. And what they found was this was about 4.8 per 1,000 in the pitavastatin group and 7.32 in the placebo group. And the study was actually they had to stop the study because of the big difference between the two. So it was about a 35% reduction in cardiovascular mortality. Which is why now in anybody with living with HIV who's over 40 years, and you could see that was almost half of my population in the clinic, you would start a statin if the LDL was high, or the risk score is relatively on the higher side, or you consider if the score is lower than 5%. And for those who are less than 40%, it's the same as people with, who don't have HIV. And the statin, we choose pitavastatin. So actually, over the last year, I put many of my people on pitavastatin. But if you don't, you can use atorvastatin, which is better than rosuvastatin because of drug interactions. So I'm actually going to, one last thing is, remember, there's a lot of anxiety, a lot of neurocognitive disorders with HIV. So we do annual screening for those. There's increased risk of cancers. Cervical cancer is a stage 4 disease in HIV, and then the psychiatric comorbidities. So I'm going to actually stop over here and just to save time and go on to the next talk. But any questions if you like, since I finished 5 minutes early, though I started 5 minutes late.
Yeah, thank you.
No?
We keep question at the end of the session. I think
Okay.
if you could wait